I would kindly invite Dr. Prabhu, Senior Consultant, Apollo Hospitals, Madurai, to present his topic on latest guidelines on anticoagulation, coagulation, and platelet disorders.
Good afternoon, everyone. Today I'm going to discuss about the guidelines on anticoagulants and antithrombotic. Why do we need these guidelines? Before going to that, we should know some history on spinal epidural hematoma. The spinal epidural hematoma was first described as spinal apoplexy in 1682 by a French anatomist. It was described in a cadaveric study. There was a blood accumulation which is compressing the spinal cord, which led to the paralysis. This was a classic early account of this neurological emergency before modern diagnosis. Nearly after 200 years, in 1869, there was a case report in Lancet. It was published by Dr. Robert Jackson, who's a general surgeon. There was a young lady who got upper limb paralysis. Initially, it was developed as a upper limb finger weakness, then it progressed to complete upper limb weakness. Later, after 4th days, he died due to respiratory arrest. In that time, they made the clinical diagnosis of spinal epidural hematoma, which was later confirmed in the postmortem study. See, the actual incidence of neurological dysfunction from hemorrhagic complication associated with neuroaxial blockade, central neuroaxial blockade, is unknown. The traditional estimates prior to the implementation of thromboprophylaxis were approximate to be less than 1,50,000 epidural placement and 1 in 2,20,000 spinal anesthesia. And after the introduction of the thromboprophylaxis, there was an extensive study conducted in Sweden. It was 10-year study. They have almost 12,60,000 spinal blockades and 4,50,000 epidural blockades were administered in those study period of time. So in that, spinal hematoma after obstetric epidural blockade carried the incidence of 1 in 2 lakh, significantly lower than the incidence 1 in 3,600 female subject to knee arthroplasty. Likewise, women undergoing hip fracture under spinal anesthesia had increased risk of spinal hematoma, that is 1 in 20,000 compared to all the patients undergoing spinal anesthesia, which is 1 in 4,80,000. The main source of spinal epidural hematoma is dorsal venous plexus because it lacks valve and it is surrounded by loose areolar tissue. So the clinical feature, the severe localized constant back pain, which will be associated with symptoms like weakness, numbness, urinary or fecal incontinence. When you are placing a catheter, the return of sensory or motor deficits several hours after spinal or epidural block has worn is pathognomic, and it should be considered and treated as spinal or epidural hematoma until proven otherwise. So the diagnosis, mainly MRI is the gold standard one. When we made a clinical diagnosis, we should order MRI as early as possible. So the management, which is urgent surgical decompression, is the treatment of choice. Previously, complete neurological recovery was considered to be unlikely if it is more than 8 hours. It had elapsed between the development of paralysis and surgical interventions. And the newer studies, they have quoted like patient taken to surgery within 12 hours had better neurological outcomes than patients whose surgery was delayed beyond 12 hours. And one more study is there. The recommended time frame for intervention has been further delineated by recent findings that recovery can be achieved when the surgery is performed within 48 hours of an incomplete motor deficit and within 36 hours of a complete motor deficit. So it is not only complication associated with central neuroaxial blockade, even peripheral neuroaxial blockade can have these kind of complications, mostly associated with hematoma. And sometimes the peripheral neuroaxial blockade is rarely with neurological dysfunction, but more typically visible bruise, local tenderness, decrease in hemoglobin or relative hypotension due to blood loss. See, there have been few case reports which is associated with lumbar sympathetic blockade with the patients on antiplatelets, where the patient developed retroperitoneal hematoma which needed an intervention later on. So to avoid all these complications only, we have these guidelines. So Astra first edition, which is started in 1998, mostly the drugs covered were unfractioned heparin, low molecular weight heparin, aspirin, and thrombolytics. So the not covered items are peripheral neuroaxial blockade, directly acting oral coagulants, and ultrasound. Astra second edition, because the rising usage of low molecular weight heparin and clopidogrel was introduced in that time only, this After second edition, the limitations were, again, the peripheral neuroxide blockade was not covered, or anticoagulants was not covered, and ultrasound guidance was not there. So the third edition, they have introduced fondaparinux. Again, the peripheral neuroxide blockade was introduced in that time only, but there was no strategy on peripheral neuroxide blockade, how to classify the blockades and all, it was not there. So the last one was Astra 4th and 5th edition came, so now we are going to combine both the one. Astra 5th edition recently released 2024. So they have mainly covered on direct oral anticoagulants. So these are used in the primary prevention of thromboembolism after elective surgeries and the prevention of stroke and systemic embolization in adult patients with non-valvular atrial fibrillation, and the prevention and the treatment of thromboembolism and pulmonary embolism. These drugs are at least as effective as anticoagulants as with vitamin K antagonist, but seem to be safer in terms of bleeding and have rapid onset of action and shorter half-life, and they are devoid of the need of routine laboratory monitoring. So the difference between the 4th edition and 5th edition is the 4th edition mainly used as prophylactic and therapeutic dose. So in one patient, which is a prophylactic dose, maybe therapeutic dose in another patient. So they are in the 5th edition, it has been updated to low dose and high dose. So this one is the 5th edition, this one is the 4th edition. In 5th edition, they have introduced low dose and high dose instead of prophylactic and therapeutic. So for directly acting oral anticoagulants, there are certain drug monitorings are there. Mainly drug-specific calibrated anti-10 assay. It should be less than 30 nanogram per ml to devoid of anticoagulant effect. If the drug-specific calibrated assay is not available, unfractionated heparin calibrated or low molecular weight heparin calibrated chromogenic anti-10 assays are also available. It should be less than 0.1 international units per ml. For dabigatran, which is a direct thrombin inhibitor, the thrombin time testing is also available. Routine coagulation tests such as PT, APTT should not be used to assess directly acting oral anticoagulants. So the only few published cases of neuraxial hematoma associated with directly acting oral anticoagulants, it is either spontaneous or traumatic in origin. Only a limited number of these cases are associated with neuraxial blockade. There is one interesting case where the patient was treated with dabigatran for atrial fibrillation. In this case, they have even stopped the dabigatran for 3 days. Then they proceeded for this epidural steroid injection for low backache. And after 24 hours, they have started the dabigatran. Patient developed massive hematoma and it was compressing the spinal cord, and they have taken up the patient for even decompression laminectomy. So the management of neuraxial blockade and deep plexus blockade, when we use the high dose of oral anticoagulant, for apixaban and rivaroxaban, it has to be discontinued for 72 hours. Dabigatran, the creatinine clearance is very important. So if the creatinine clearance is more than 50, 72 hours of stoppage, 30 to 49, 120 hours. If it is less than 30, don't give any neuraxial blockade for the patients. So the monitoring is very important. Actually, it was not given in the 4th edition. 5th edition, they are recommending to do monitoring before even proceeding this one. So the residual plasma level should be less than 30 nanogram per ml for both apixaban, rivaroxaban and also dabigatran. And the drug can be reinitiated after 24 hours of the procedure. So this is for the low dose. For low dose, again apixaban 36 hours, rivaroxaban 24 hours and dabigatran 40 hours to be stopped before giving any procedures. Again, monitoring is recommended for the same thing, and it can be reinitiated after 6 hours. So the indwelling neuraxial catheter is not recommended when the patient is on directly acting oral anticoagulants. So the reversal agents also available for apixaban, rivaroxaban, andexanet alpha, and idacruzumab is a monoclonal antibody which can reverse the dabigatran. FDA approved only for reversal of anticoagulants is needed in an emergency, life-threatening or uncontrolled bleeding. Present data suggests against the use of reversal agents to enable the safe performance of the neuraxial interventions in routine patients. Unfractionated heparin, 4 to 6 hours we have to stop before the procedure. Indwelling catheter, continuous IV administration is not recommended, but IV heparin can be given after 1 hour of the procedure. So occurrence of bloody needle placement, no data support to mandatory cancellation of the case. So any patients on heparin for more than 4 days, we have to assess the blood count. Subcutaneous heparin for low dose 4 to 6 hours stop, then we can proceed with we can place the needle. Indwelling catheter, there is no contraindication, only in low dose. After doing the procedures, if you want to remove the catheter, 4 to 6 hours stop, and the subsequent dose can be started immediately. In the high dose, it is 12 to 24 hours. Indwelling catheter, the safety is not established. Low molecular weight heparin, for more than 4 days of low molecular weight heparin, platelet count has to be done. And again, blood tap, delay low molecular weight heparin 24 hours post-operatively. Antiplatelets or oral anticoagulants in combination with low molecular weight heparin, it increases the risk of neuraxial hematoma. So recommendation is against the use of low molecular weight heparin with the combination when there is an indwelling catheter. So low dose low molecular weight heparin, needle placement 12 hours after stopping it. Indwelling catheter only in low dose, not in the high dose. Post procedure 12 hours after the placement, and 12 hours after stopping we can remove the catheter and restart in 4 hours. In high dose, needle placement after 24 hours, no indwelling catheter, 24 hours after non-high bleeding surgeries, or 48 to 70 hours after high bleeding surgeries. Again, drug monitoring is recommended in these situations. For antiplatelets, aspirin low dose, no need to stop, we can give the procedures. Clopidogrel 5 to 7 days. So I want to emphasize on silastosol, which has been still used with the vascular surgeons. Silastosol we have to stop 48 hours, and then only we have to proceed with the neuroxil procedures. So direct acting thrombin inhibitors, parenteral inhibitors. In patient receiving parenteral thrombin inhibitors, suggestions are against performing the neuroxil techniques. Next, fondaparinux. On lower dose with the normal renal clearance, hold for 36 hours to 42 hours. If the depends upon the creatinine clearance, it can go up to 72 hours. Anti-tenia monitored to be done in this case. High dose 70 hours to 105 hours. Restart after the procedures at least 6 hours later. Fibrinolytic therapy or thrombolytic therapy. If they are scheduled to receive the fibrinolytic therapy, avoid for 10 days following the puncture of non-compressible vessel or neuraxial anesthesia. If they receive the therapy, we have to wait for 48 hours before proceeding with any neuroxial procedures. Patient receive neuroxil blockade at or near the time of fibrinolytic or thrombolytic therapy. Frequent neurological monitoring, that is every 2 hours, should be continued for at least 48 hours after the last dose. Unexpectedly receive the therapy with indwelling catheter. Measurement of fibrinogen level before the catheter level, or after removing also neurological monitoring for 48 hours is recommended. Warfarin, stop 5 days, check the INR, if it is normal, we can place the needle. Indwelling catheter, again it's not recommended. Restart after the catheter removal. So the nerve block categories, for peripheral nerve blocks, if it is a superficial nerve blocks, we can even proceed with all the anticoagulants or this antiplatelets and all. For deep nerve blocks, it should be considered as neuroxil block. For deep nerve blocks, the most of the blocks what we are performing, the upper limb infraclavicular block, apart from this epidural and spinal, lumbar plexus, psoas compartment block, proximal approach of sciatic block, PENG block, all those things, we have to apply the same guidelines before proceeding for the surgery. So is there a role of ultrasound? Ultrasound reduces the vascular puncture, and therefore its use is recommended in patients on anticoagulation and antiplatelet drugs. But ultrasound guidance has no influence on the time interval from the last administration of antithrombotic drugs prior to superficial or deep plexus block or to the next drug dose after the block. Thank you.